Okay, thank you very much. So first of all, let me apologize for all the technical errors, and I wish I could be there, and it would have been much simpler, but unfortunately it was not possible. So without further ado, I will start. In the name of Allah, the most gracious, the most merciful. These are my disclosures. You can go through them real quick. Okay, so what we are going to talk about today is basically an introduction. We are going to go over the glucocentric approach. We are going to discuss the metabolic interplay between type 2 diabetes and cardiovascular disease. We are going to transition to a complication-centered approach, practical implications for clinical practice, future discussions, and by concluding the whole talk. So I think there are so many numbers that are there in front of you on the screen, but none of you need to understand how the prevalence of diabetes is affecting us. The way that I generally describe it to my friends and my family is that either I am a diabetic, or a family member is a diabetic, or someone that I love is a diabetic, or a friend is a diabetic. So it is affecting each and every one of us. This is the prevalence of diabetes in Pakistan, and as you can see from the year 2011 till now, it has gradually been going up till the most recent one, which shows a 30.8% prevalence. And I'm sure you see that in your daily practice. Now the important thing is, hello, is that okay? Can I continue? Okay, all right. So the reason that any of us manage diabetes is very simple. We are not just focused on getting the glucose levels down. We are, in fact, trying to achieve the goal of decreasing the cardiovascular morbidity and mortality. From the data that you have in front of you, we can see very clearly that in terms of the type 1 diabetes, in terms of the blue line that is on top, and when you compare to the red line, which is basically the matched controls, you can very well see that there is a significant change in terms of death from any cause between people who have type 1 diabetes as compared to their matched controls. Similarly, death from cardiovascular disease, coronary heart disease, and cardiovascular disease, all of them, there is a significant change in terms of the people who are suffering from or dying from any cardiovascular cause as compared to matched controls. What about type 2 diabetes? This is the data in front of you, and you can very well see here as well that type 2 diabetes has a similar picture in terms of comparison between people with type 2 diabetes and the matched controls. So it is extremely important for us to make sure that we are making an impact in terms of the cardiovascular disease morbidity and mortality in our patients with diabetes. Now, if you look back historically, you can see that when we started managing diabetes a few hundred years ago, we were just focused on the fact that we will decrease the blood glucose level, because that's where our understanding was in terms of the fact that the glucose level is what is the prime thing in diabetes. If we can bring the glucose level down, we will achieve our primary goal. So that continued for decades on end, but then as the cardiologist before me was explaining, and I'm really glad that he had brought out that point, was that just decreasing the glucose levels had a very limited impact in terms of these cardiovascular morbidity and mortality that I just shared with you. And as he very nicely pointed out, we were ignoring the factors like hypertension, dyslipidemia, and inflammation. So what is diabetes, and what do we mean by the term glucocentricity? So if you take the definition of WHO, it has defined diabetes as a chronic metabolic disease characterized by elevated levels of blood glucose or blood sugar, and that in time causes serious damage to the heart, blood vessel, eyes, kidneys, and nerves. So, in the earlier days, the idea was to keep the blood glucose levels as close to normal as possible, and later, when we started to focus on hemoglobin A1C, we then wanted to get that as close to normal as possible. So this basic focus on the glucose alone is what defines the glucocentric approach. So normalizing A1C over time became our primary goal, but still it was glucose-centered. If we look back, in 1979, for those of us who were practicing or learning about diabetes at that time, the diagnosis of diabetes was at a glucose level in fasting of 140. However, by 2003, this was changed to a fasting plasma glucose of 126 or more. And the important thing to remember here is, what is the basis of this change? You see a lot on the social media that whosoever, they changed the level from 140 to 126, and overnight so many people became diabetics. Now the question here is, which I think is my first message of the day, is the fact that these numbers are based on evidence. Evidence such as complications that result from diabetes. For example, in this case, retinopathy. When we were diagnosing people with diabetes at a level of 140, a substantial number of them already had the complications of retinopathy. Therefore, it didn't make any sense to say that we are diagnosing with you with diabetes now, but you already have complications. So data was reviewed to see where exactly do we see an increase in these complications such as retinopathy, and a number of 126 was then reached upon. Now, as I said to you earlier, that hemoglobin A1C also plays a significant role in the diagnosis of diabetes, and therefore the threshold for hemoglobin A1C was greater than or equal to 6.5% or more. And as you know, it has to be confirmed in 2 separate occasions before we make the diagnosis of diabetes. So if you then put it in a historical perspective, we can see that diabetes management has gone through 3 different stages or eras. So we will go through these 3 eras of diabetes management real quick. So the first era of diabetes management was what we talked about just now, which was focused on normalizing the hemoglobin A1C. And where did this historically start? As you all know, was the UK PDS trial, which showed that we need to bring the hemoglobin A1C down to manage diabetes. However, again, as we know, that although we saw some improvement in the microvascular complications, but the macrovascular complications such as myocardial infarction or stroke, they didn't show any significant change. In the second era of diabetes management, what we then said, okay, if it were that we are bringing the blood glucose levels down to normal and it is not making an impact, why shouldn't we then go for intensified control, that is, control the blood glucose levels tightly or even further down than normal? And as was mentioned just a little while ago, trials such as ACCORD, VADT, and ADVANCE, they showed that, in fact, intensification backfired. We basically had complications such as weight gain and hypoglycemia, but there was no significant impact in terms of the complications. Then, with that learning, we have now moved to the third era of diabetes management, which moved from just focusing on the control of diabetes onto an organ protective approach. What does that mean is that we are now focused not just on decreasing the blood glucose levels, but also on the fact that how can we reduce the complications. And the main focus is the cardiorenal risk. And this is what you are now hearing a lot about, that the drugs that we have now should not only have an impact in bringing the blood glucose level down, but they also should have an impact on the cardiovascular complications that happen because of diabetes. In other words, and this is my second focus for today, is that a drug that brings down the blood glucose level but may have a negative impact on the cardiovascular outcomes is not the drug to be used to manage diabetes. You need a drug that not only brings the blood glucose levels down, but also has a positive impact on the goal that we are trying to achieve, which is decrease the cardiovascular or cardiorenal risks. So this is now the third era of diabetes management. So in terms of what we are talking about today, which is the metabolic interplay between type 2 diabetes and cardiovascular disease, the outcome that we are all focused on, we are going to very quickly talk about how this high sugar is contributing to the cardiovascular risk by affecting the endothelium lining the inside of the blood vessels, and how do these hyperglycemia, insulin resistance, and dyslipidemia are affecting the cardiovascular complication development. And we are going to quickly look at the recent trials which did show us the cardiovascular benefit from these drugs, which are not only focused on glucose alone, but have effects beyond glucose control. And finally, we are going to then put all of this together to see how this has changed the way that we manage diabetes. So, as you know, and as we just said, the diabetes leads to hyperglycemia, which is high blood sugar. It has insulin resistance built in type 2 diabetes, and in the initial stages, we have an increased insulin level. And what does this lead to? Multiple things, as you see in the second line, such as atherosclerotic cardiovascular disease, metabolic disturbances, structural alterations, etc. But let's focus on the first one here, which is atherosclerotic cardiovascular disease. What does that lead to is basically ischemic cardiomyopathy and ultimately heart failure, whereas all the others then contribute towards diabetic cardiomyopathy and ultimately heart failure and death. So I'm not going to go into the details of this slide, but basically, as you all remember, that there are lipid particles in the blood, and over time, because of the inflammatory pathways, there is endothelial dysfunction. The monocytes enter the muscular wall, and then there are foam cells and macrophages where cholesterol is deposited, leading to thrombus formation. And when the core becomes necrotic, there is platelets that are there to interact with this, and that leads to the cardiovascular complications that happen. As you can see from the three lines below, this happens all the way from pre-diabetes onto the diabetes stage. It is worsened by insulin resistance and hyperglycemia. So what about the trials that we spoke about earlier, and how do they affect MACE, which is the major adverse cardiovascular outcomes, the all-cause death, as well as hospitalization for heart failure? In the red, we have the GLP-1 receptor agonist. In green, we have the SGLT2 inhibitors. And in the blue, we have the DPP-4 inhibitors. As you can see, in terms of MACE, the GLP receptor agonists, most of them have a very positive impact. As you can see from this forest plot here, they are all to the left of the dotted line. The SGLT2 inhibitors are again in the same category. DPP-4 are in the middle. They are not harmful. They are not, maybe not as helpful as GLP-1 receptor agonists and SGLT2 inhibitors. Similar picture emerges for all-cause death. And finally, hospitalization for heart failure as an indicator alone. You can see the effect of SGLT2 inhibitors, which is remarkable in decreasing the hospitalization for heart failure. So the point here, the third point here for the day is that if you look at these drugs, they are not only decreasing the blood glucose levels, but they are also impacting the cardiovascular outcomes that we are all focused on in the management of our patients with diabetes. Now, how this has impacted the diabetes guidelines over time. Not that far ago, 1989, when the standards of care were published for the first time, it were only 4 pages long. And this year, these are 314 pages long. And not only they focus on glucocentricity, but cardiovascular outcomes as well. This is 15 years ago. What you see here is that we were focused on hemoglobin A1C alone, and if the hemoglobin A1C was greater than 7%, we would add either basal insulin, and at that time it was considered the most effective, or sulfonylurea, or we added a glitazone such as pioglitazone or troglitazone that was available earlier. So basically, those were the drugs that were available, and as you just scan down on this slide, you will see various combinations of these 3 or 4 drugs were there, and this is all we had as far back as only 15 years ago. 5 years ago, we were still focused on diabetes in terms of glucose. Here, we did at 9%, and just remember that number, at 9%, we were considering dual therapy. And the whole idea was, when one fails, add the other agent. When that fails, add the other agent. So it was a sequential approach. And that was not very long ago. That was 5 years ago. And now, as you can see, it has all changed because of the data that I have shared with you. Now, as you can see in the green box there, we have to look for high-risk individuals with type 2 diabetes. We need to find out if they already have atherosclerotic cardiovascular disease, or they have indicators for high risk, or they have heart failure or chronic kidney disease. In that event, we need to move on to a GLP-1 or an SGLT2 much earlier than we have ever done in the prior years. So that now is the focus of diabetes management. So this is where we are now transitioning to a complication-centered approach, and we have now a broader focus on preventing the complications, as we said, including cardiovascular disease, and we now have a multi-risk factor management, as I said, that was mentioned earlier, in terms of the blood pressure, the lipid levels, and the renal function. And the therapeutic strategies, as I just showed you, the use of SGLT2 inhibitors, GLP-1 receptor agonists, and other agents with proven cardiovascular benefits, because there is evidence to support us with that. So the final thing here to remember is that in your practice, you see this every day, that one medicine is not going to affect each and every one of your patients. Some patients will be responding better to one class of medication, and the other ones may not be responding to it at all. And that's where you, with your experience and your knowledge, adjust the therapeutic regime to come up with the one that works best for your patient. So now we know, as I've shown you earlier, that the guidelines and algorithms emphasize cardiovascular risk reduction in diabetes management, and we have moved from a glucose-centered approach to a complication-centered approach. And I'm just going to share one algorithm, which is from the American Association of Clinical Endocrinology, which, as you can clearly see here, starts with lifestyle intervention, and then we look for the risk factors. But I wanted you to focus on this red box with the arrow there. Remember when I showed you that earlier on, when a hemoglobin A1C was 9, we were going to start the second agent. Now, as you can see, the recommendation is that if the A1C is greater than 7.5, you are advised to start 2 agents, and above 9, or 1.5% above the goal that you have set for that patient, you need to start maybe 2 or 3 agents. So the problem here, and I'm sure it is worldwide because this is a problem that we see here in Dubai as well, is the fact that when you move to 3 medications, the problem is twofold. Number one, the patient doesn't want to take as many medications. And number two, the cost adds up. So here we have a tough time of encouraging patients to take 2 or 3 medications. And then for those that have to pay for it, it's a major cost. However, in Pakistan, because a lot of our patients are now going and getting medications from Pakistan, we do have triple combination of a complete range is available in Pakistan. For example, EMPA, Lina, and metformin sustained release, that is available as a combination, and the costs are far, far less than what we ever see here in Dubai. The only quick point here is the metformin sustained release. As you know, from your own practical experience with all your patients, a lot of them have GI effects when we use immediate release metformin. So the extended release formulation, along with the other agents, is a good way to go to achieve our goal of getting the blood glucose level down, as well as getting the cardiovascular benefits from these agents. What about multidisciplinary teams? Now, this is a very busy slide, and I'm not going to go through all of it. The point is that, yes, I work at a diabetes center. Yes, I have diabetes nurse educators and dietitians and what have you. But management of diabetes requires a team effort. I understand that a lot of us will not have access to the dietitians and the nurse educators, but we do have access in terms of material, the educational material that we have, in terms of what sort of diet that we can provide our patients, what practical tips we can give our patients. So all I'm promoting here is that we need to keep our minds open in terms of the overall treatment plan that these patients need. We have, excellent societies in Pakistan which are helping us create these this educational material that we give out to our patients in terms of their diet, their exercise plans, and what have you. So unfortunately, unlike a lot of other situations that we deal with, that we can just give medicine and hope and the patients get relief from it, in terms of diabetes, it is a little bit beyond just the medication therapy. It needs a lot of lifestyle modification as well. And as I've showed in the previous slides, the basis of management, the first thing that everyone will advise is lifestyle modification. So here, we need to have, if not a team, then at least the resources, all that are possible, to give the best possible care to our patients with diabetes in terms of lifestyle modification on top of the medications. Now, diabetes is a disease in which all aspects of life are impacted, and therefore it is important to have the patient engagement in there. So this is a very quick mnemonic that please ensure that your patients are participating in the decision-making process. They know what the options are. You understand what the patient's values and preferences are. And then you together